So today was all about novel agents and where they fit into the landscapes in the treatment of and the management of lymphoma, starting off with debates, thinking about the kind of area more philosophically, and then going into kind of more didactic presentations of what we think about in the various classes of drugs. I guess we could start very easily with Ibrutinib, which of course you've done with Lou Stout a huge amount of work. This is a drug, of course, which is approved already in CLL and in mantle cell lymphoma, but I think what we're all really intrigued by is the more recent data that you and Lou have been doing in diffuse large B-cell lymphoma, and particularly the notion of how it's a scientific understanding of a subtype of lymphoma, recognizing a target, then applying it. That's a very satisfying way to do clinical trial development.
Sure. You know, I think this is a very exciting time, because if we roll the clock back 5 or 6 years, none of these drugs even existed. And this is a very good example of how our understanding of certain molecular pathways has in large measure come from actually using drugs. And by that I mean BCR signaling, or B-cell receptor signaling, which is intrinsic to B cells, has always been a suspected survival mechanisms for CLL, and also to a lesser extent for mantle cell, for follicular, and for large cell. And really, with the advent of a drug that actually interferes with a key protein kinase within that cascade, we have now seen dramatic responses in CLL, mantle cell, and that therefore generated a lot of investigation and has really revealed the fact that the BCR signaling is a key survival mechanism for all these different tumors. So this is really an interesting paradigm where the clinical work has really informed what we have now begun to understand from a molecular point of view. And I think that this is especially intriguing and perhaps more examined in depth in large cell, where we now know that large cell lymphoma, the most common type of lymphoma, is not a single type of tumor. It's actually multiple types of tumors. And the subtype of large cell called the activated B cell type is the type that seems to affect older folks more. And so it is a disease where we really do need improved outcome, because with standard therapy, the outcome is worse than the other types. And work that Lou Stout has done, both from the molecular point of view and work that we've been doing with him on the clinical trials, has, number one, identified BCR signaling as key, and also has identified a variety of different mutations within the BCR signaling cascade that actually lead to enhanced BCR signaling within the tumor cells. And what Lou and I have been able to show, at least in a small study, is that depending on where these mutations are, being able to inhibit BCR signaling more upstream actually can have a differential effect clinically, such that if in fact some of the activating mutations is below the Bruton tyrosine kinase, which is Ibrutinib's target, in fact BTK does not work. Whereas if it's not there and they're signaling above Bruton tyrosine kinase, the drug seems to have very good activity. And so this was very exciting work, and it's actually led to a large randomized study where R-CHOP has been, where patients are randomized between R-CHOP with or without Ibrutinib. These are untreated patients, and these are patients with the non-germinal center type of large cell, those that have mostly BCR signaling. And this trial, called the Phoenix trial, actually has been completed in record time. It has taken under 2 years to accumulate almost 900 patients on this clinical trial. And I think that we're all anxiously awaiting to see whether or not Ibrutinib is able to improve the cure rate and the survival of patients with ABC. The last time, and really the only time we have seen a targeted agent in the last 30 years improve survival and cure rate was when rituximab was similarly studied in the late 1990s. And that really led to a revolution, not just in large cell, but across all B cells. And I really feel very optimistic that Ibrutinib through a different pathway will be similarly transformative for the treatment of these types of tumors.
There is, of course, the issue of the cost of these agents and the idea that once you're on these agents, you go on it for life. Do you think that's the future of these drugs, or do you think we have to find ways to put these drugs together in the right combination to get patients on and off the drug again, or do you think there's really a role for lifelong maintenance?
Sure. So, you know, I think that there's room in medicine for each approach. I think when you're dealing with a tumor that can be possibly cured, such as large cell, it makes most sense to use these agents during the chemotherapy itself, which is only given for a limited time, to enhance the probability of cure. And I think that after you hopefully cure somebody with, let's say, 6 cycles, that with curative lymphomas, there's no need to give it afterwards. I think for lymphomas that we typically don't consider to be curative, such as follicular lymphomas, CLL, the whole strategy has been to give these as single agents. And as single agents, they worked very well. People are staying on them long periods of time. But I think that you bring up a very important issue, and that's cost, but also, quite honestly, these drugs are not without side effects. And although they may be mild, you know, chronic fatigue, susceptibility to abnormal heart rhythms, to diarrhea, are not things that patients are necessarily going to want to have to endure year over year.
Year after year after year.
And so I think that the whole field now is moving toward combining these with other targeted agents, with chemotherapy. And my hope is that as we combine them, that we may be able to give more conventional, you know, limited cycles. The problem with giving them as single agents is they do not eradicate the tumor. Although they can bring the tumors down to very low levels, even getting rid of them in terms of what we would look at for conventional scanning, such as CT scanning, it is very unusual to get a complete remission with these drugs. So I think that they also need to be studied in combinations with perhaps chemotherapy regimens, other targeted regimens, other targeted therapies, where they're given for limited periods of time. And then we can see, can we possibly even change the natural history of more conventional limited therapy in these diseases when we add these new targeted agents?